Hello everyone. So already we have covered the first session today and we have covered the important all the important MCQs and the topic related to the general anatomy, upper limb and thorax. Today I would like to start with lower limb. A very important topic of the lower limb will be covered here and most important topic. Then I will go with head and neck neuroanatomy. So let's start with the first topic here, lumbar plexus. So when I am talking about lumbar plexus, it's important for you to know how this plexus is formed and what are the important branches of lumbar plexus. Whenever I'm using the word plexus, what does that mean? It means a bunch of nerves. Okay, it means a group or bunch of structure. So here lumbar plexus means bunch of nerves. So lumbar plexus is a network of nerve fibers that is supplying the skin and the musculature of the lower limb. It is exactly located in the lumbar region and it is passing through the psoas major muscle anterior to the transverse process of the lumbar vertebra. The plexus is formed by the ventral rami, that means anterior rami of the spinal nerves of the following spinal nerves L1, L2, L3 and L4. My dear aspirants, please note down. The contribution from T12 is not fully, it also receives a communication. But if an MCQ comes that lumbar plexus is formed from all the following nerve roots except, you will mark T12 as the answer because it is not taking the contribution of whole of T12. Sometimes a contributing or a communicating branch may communicate with the lumbar plexus. But if I talk about lumbar plexus formation, it is from the anterior rami, ventral rami of the lumbar spinal nerves, that is L1, L2, L3 and L4. Now let's see the important branches of lumbar plexus. The important branches of lumbar plexus has been demonstrated here. So let me slightly enlarge this image. So when I am enlarging this image, you can see here L1, L2, L3 and L4 is taking part in formation of lumbar plexus. A communicating branch from T12 is contributing to it. And the important branches are iliohypogastric, ilioinguinal, genitofemoral, lateral cutaneous nerve of thigh, direct branches to psoas and iliacus, femoral nerve, obturator and accessory obturator nerve. So all these are the branches of lumbar plexus. So branches of lumbar plexus, if you want to note down, please note down the important branches of lumbar plexus already shown in the image. But quickly we can write the branches. The branches are iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, direct branches to psoas and iliacus muscle, lateral femoral cutaneous nerve of thigh, lateral femoral cutaneous nerve of thigh, femoral nerve, obturator nerve and also the accessory obturator nerve. Accessory obturator nerve. So these are the branches of lumbar plexus and the formation of lumbar plexus is from the ventral rami or anterior rami of L1, L2, L3 and L4. Now my dear aspirants, let's see the front of the thigh cutaneous distribution. So when you see the front of the thigh, you can see the distribution of cutaneous nerve has been shown. On the lateral side, we have got lateral cutaneous nerve of thigh, which is a very important nerve and it is important for the giving cutaneous sensation on the lateral side of thigh till the level of lateral aspect of the knee joint. When this nerve is compressed or there is pressure over lateral cutaneous nerve, it can lead to a clinical condition called as meralgia paresthetica. So compression of lateral cutaneous nerve leads to a condition called as meralgia paresthetica. Now, if I talk about the other nerves contributing to the nerves, here we can see intermediate cutaneous nerve is there, obturator nerve, medial cutaneous nerve of thigh, and also we can see the contribution has been shown from the femoral branches of genitofemoral nerve. Now, let's talk about the modification of fascia lata. What is fascia lata? When I am talking about the word fascia lata means the deep fascia of the thigh. So, whole of the muscles we know in the front of the thigh and also in the medial compartment, posterior compartment of the thigh, it is containing muscles. All these muscles are wrapped by the deep fascia, and this deep fascia of thigh is called as fascia lata. There is three modification of the deep fascia. One is the iliotibial tract, saphenous opening and intermuscular septa. What is intermuscular septa? It is dividing the compartments of the thigh. Means intermuscular septa, which is the modification of deep fascia, is dividing the three, it's forming three compartments in the thigh, the anterior, the posterior and the medial compartment of the thigh. Saphenous opening is an oval opening which is covered by cribriform fascia and through which great saphenous vein drain and passes and drains into the femoral vein. Iliotibial tract is the thickening of deep fascia of the thigh, and it is seen on the lateral aspect of the thigh. It extends from the iliac tubercle, and to the lower aspect it extends towards the lateral aspect of the knee. So, here I would like to show you the image of the fascia lata, which is shown here, and you can see an ovoid hiatus is there, which is called as saphenous opening, which is lying below inguinal ligament and lateral to pubic tubercle. Great saphenous vein drains through this opening and ultimately drains into femoral vein. Iliotibial tract, as I told you, in the iliotibial tract, which is a modification of deep fascia, two muscles are inserting. One is tensor fascia lata, another is gluteus maximus. Firstly, I want you to show this image. So, see this image here, you can see this is the iliotibial tract, which I am highlighting with green color. This is the iliotibial tract, which is the modification of deep fascia, and what you can appreciate in this diagram, that the gluteus maximus muscle is inserting and also the tensor fascia lata is inserting in this iliotibial tract, and in the superior aspect, iliotibial tract is attached to tubercle of iliac crest, which is the superior, iliac crest is the superior border of the ilium part of the hip bone, and lower down it is attached to the lateral condyle of the tibia. Now, two muscles inserting into iliotibial tract, one is gluteus maximus and other is tensor fascia lata. So, what is iliotibial tract? It is a modification of deep fascia of thigh. Please write down iliotibial tract. It is the modification of deep fascia of thigh. It is the modification of deep fascia of the thigh. Two muscle inserts into iliotibial tract. These two muscles are, iliotibial tract is also called as iliotibial band. Two muscles inserting into it is gluteus maximus muscle and the other is tensor fascia lata. TFL I have written in short form. So, the one is gluteus maximus and the other is tensor fascia lata. These two muscles are inserting into iliotibial tract. This is very important for your MCQs. Now, let's talk about other important topic of anterior aspect of the thigh region, that is the femoral triangle. Okay, so we will talk about the femoral triangle. Femoral triangle, when I am talking about a femoral triangle, it is a triangular depression in the anterior aspect of the thigh. It is bounded laterally by sartorius. It is bounded laterally by sartorius and medially by, if I talk about its medial boundary, so you can just appreciate in this diagram, medially it is bounded by adductor longus muscle. Superiorly, or the base is formed by inguinal ligament and the apex is formed by overlapping of the sartorius muscle over adductor longus muscle. So, this triangular depression is lying on the anterior aspect of the thigh. So, we have seen the boundaries. Now, it's also important to know the skin, it's also important to know the roof, which is covered by the skin, superficial fascia, and there are certain important structures in the superficial fascia of the roof of femoral triangle. In this diagram, what you can appreciate, the muscles which is forming the floor of femoral triangle. Now, here you can see the floor of femoral triangle is having adductor longus muscle, the pectineus muscle, the psoas major muscle, and more laterally is the iliacus muscle. So, these four muscles are forming the floor of femoral triangle. You can remember the muscles forming the floor of femoral triangle from medial to lateral by a mnemonic API. I will write that, don't worry. Then, so firstly, let's write the femoral triangle boundaries and that of the floor. Femoral triangle boundaries. The boundaries of femoral triangle is laterally, it is bounded by medial border of, laterally it is bounded by medial border of sartorius muscle. Medially it is bounded by medial border of or medial aspect of adductor longus muscle. Coming to the base, when I am talking about the base is formed by inguinal ligament. The base is formed by inguinal ligament and the apex is formed by sartorius muscle overlapping the adductor longus muscle, or you can say the meeting point of the lateral and medial border is forming the base. If I talk about inguinal ligament is formed from the aponeurosis of external oblique muscle, and the extent of inguinal ligament is from anterior superior iliac spine to pubic tubercle. So if you want to note down, please note down. Inguinal ligament is formed by the aponeurosis of external oblique muscle it extends from the extent of inguinal ligament is it is extending from anterior superior iliac spine to PT means pubic tubercle. Now coming to the floor. If I talk about the floor of femoral triangle, it is the mnemonic is API from medial to lateral. So the floor of femoral triangle from medial to lateral is formed by following muscles. It is formed from the following muscles. It is formed from the following muscles as you proceed from medial to lateral. The mnemonic is API. So here APPI, API. A stands for adductor longus muscle. So please note down, adductor longus muscle is not only forming the medial border of femoral triangle, but it is also contributing to form the floor muscle. Another P for pectineus and another P for psoas major muscle. I for iliacus. Now, so these are the floor muscles of femoral triangle. Now moving on to the roof. When I talk about the roof of femoral triangle, so for that firstly I want you to show this image. So actually we know that it's very important for us to know the femoral triangle contents, but it is also important to know the content of superficial fascia of the roof. So if I talk about the content which is residing inside, what the most important content is femoral vein, artery and nerve. Okay, so if you proceed from lateral to that of medial, the mnemonic is navel, N-A-V-E-L, navel. Here N stands for femoral nerve. So this is the femoral nerve. So we have got femoral nerve. So this is the femoral nerve. Along with it, more laterally, femoral branch of genitofemoral nerve is also there. Then the next structure which you can see in the red color, this is femoral artery, and the medial-most structure is femoral vein. Then we have got an empty space, and the most medial-most structure is femoral canal, which is containing lymphatics, deep inguinal lymph node. So that means femoral nerve, femoral artery, femoral vein and lymphatics are the content residing inside femoral triangle. Other than that, it also contains lateral cutaneous nerve of thigh, deep inguinal lymph node, and it also contains the branches of femoral artery. Actually 6 branches of femoral artery, 3 deep and 3 superficial is residing in the femoral triangle. Now, if I talk about the content which is residing in the roof, when I talk about the content which is residing, if I talk about the inguinal lymph nodes which is residing in the content inside, that is deep inguinal lymph node, but superficial inguinal lymph node is the content of the roof structure that is located in the superficial fascia of the roof. Now, Other than that, the other contents in the roof is branch of ilioinguinal nerve, superficial branches of femoral artery accompanied by the tributaries of femoral vein, upper part of great saphenous vein which is draining into. So you can see here, this is the great saphenous vein which drains into femoral vein. Great saphenous vein is the content of roof, and also the superficial inguinal lymph node. So please write down the content separately for the roof and separately for the content residing inside. So firstly, I want everybody to note down roof of superficial fascia, roof of femoral triangle. So when I talk about roof of femoral triangle, when I am talking about roof of femoral triangle, it means we are talking about the structures which is covering, which is forming the roof of femoral triangle, and that is formed by skin and superficial fascia. Skin and superficial fascia. Now, so here the superficial fascia is containing, if I talk about the roof superficial fascia, it is containing following structures. It contains superficial inguinal lymph nodes. It contains femoral branch of genitofemoral nerve. It contains branch of ilioinguinal nerve, It contains superficial, the other contents is, it also contains superficial branches of femoral artery and accompanying veins. It also contains upper part of great saphenous vein or long saphenous vein. So these are the important contents residing in the roof of femoral triangle. When I have written the word superficial branches of femoral artery, I mean 3 branches, that is superficial circumflex iliac, superficial epigastric and superficial external pudendal. So these 3 superficial branches along with the accompanying vein are residing in the roof of femoral triangle. Femoral branch of genitofemoral nerve and superficial inguinal lymph node, ilioinguinal nerve and upper part of great saphenous vein. Now let's talk about the content. So let's separately write the content. Few things are common but few things are different. So we'll write the content of the roof and content which is residing inside the femoral triangle separately. So the word is content of femoral triangle. So a very important mnemonic is there, that is called as navel. That is the content from lateral to medial. So this mnemonic will help you to understand the content from lateral to medial. So that means NAVEL. So here N stands for femoral nerve, A stands for femoral artery, V stands for femoral vein, E for empty space, there is an empty space, and then we have got the structure that is called as lymphatics. Which lymphatics? Deep inguinal lymph node. Actually, deep inguinal lymph node is also called as lymph node of Cloquet or Rosenmuller. The other name of deep inguinal lymph node is, it is also called as lymph node of Cloquet or Rosenmuller. Now, here femoral nerve, along with the femoral nerve, the other nerves which is also seen here there will be also femoral branch of genitofemoral nerve, femoral branch of genitofemoral nerve. Femoral vein with and its tributaries will be lying as a content. Other nerve which is also the content here. So if I talk about the most important content here is the femoral nerve, but few more other nerves are also forming the content. So here you can write down, add on more contents here. One is femoral branch of genitofemoral nerve, the other is lateral cutaneous nerve of thigh. So that means femoral nerve, lateral cutaneous nerve of thigh, femoral branch of genitofemoral nerve, all is the content of femoral triangle. If I am writing the word arteries, so there is 3 superficial branches and there is 3 deep branches of femoral artery as the content. So I will write down the 3 superficial and 3 deep branches of the femoral artery as the content of femoral triangle separately, because there is less space here. Femoral vein and distributary, empty space, deep inguinal lymph node. That means deep inguinal lymph node are the medialmost content of femoral triangle, which is located in the medialmost part, femoral canal, and it is also called as lymph node of Cloquet or Rosenmuller. So please write down. We have just written femoral artery has got 6 branches as the content in femoral triangle. As a content in femoral triangle. So now here 3 superficial branches are, the name of 3 superficial branches are, and we will write the name of 3 deep branches. So please write down. Okay, the 3 superficial branches are superficial external pudendal, superficial epigastric artery, and superficial circumflex iliac artery. Superficial circumflex iliac artery. The 3 deep branches are, profunda femoris artery, a very important branch of femoral artery, profunda femoris artery, deep external pudendal, and the muscular branches. So all these 6 arteries are the content of femoral triangle. So done with this, now we have done with the femoral triangle. Now here I just want to show you the femoral artery and its important branches as a content in femoral triangle. So you can see here, let me use red color for it. So you can see external iliac artery. This external iliac artery below the level of inguinal ligament. So this is the inguinal ligament. It changes its name to femoral artery. So this is the femoral artery. So this is exactly the femoral artery, and this is external iliac artery below the level of inguinal ligament, which is shown in the green color. The external iliac artery changes its name to femoral artery. The 3 superficial branches. So let me show you the 3 superficial branches. The 3 superficial branches are superficial epigastric, superficial external pudendal, and superficial circumflex iliac. So these are the 3 superficial branches. The 3 deep branches are profunda femoris artery, a very important branch, profunda femoris artery, the deep external pudendal, and these muscular branches. So these are total 6 branches of the femoral artery, which is given in the femoral triangle. Other branches which is shown here is descending genicular artery, which is exactly traversing through the adductor canal, and in the adductor canal it also gives saphenous branch. So my dear aspirants, let's see this. Now I just want to show you one more image where actually profunda femoris artery is a very important branch. It's the largest branch of femoral artery, and this profunda femoris artery again gives a very important branches. So this profunda femoris artery is a very important and largest branch of femoral artery. Other branches which it gives is lateral circumflex femoral, muscular branches, medial circumflex femoral, and perforating branches. So these are 4 important branches: lateral and medial circumflex femoral, muscular, and perforating branches. The lateral and medial circumflex femoral artery, as you can see, it again gives 3 more branches which are ascending, transverse and descending. Actually, these branches take part in the formation of anastomotic network in the back of thigh. Now, I want you to show a cadaveric image where you can appreciate the femoral triangle. Here you can see the adductor longus muscle very nicely has been appreciated. This is the adductor longus muscle. Here you can see the adductor longus muscle forming the medial boundary, the sartorius muscle which is forming the lateral boundary, and above we have got the inguinal ligament forming the base. The content which is shown inside, so we can see the femoral artery which I have highlighted in the red color, femoral artery. Medial to it we can see the vein, femoral vein, and lateral to it we can see the nerve. So, 3 important contents. Let me just write here. This is femoral nerve, this is femoral artery, and this is the femoral vein. Okay, so these are the 3 contents which is also highlighted in this image. Now, again this is an image in which you can see there is white sheath which is covering the femoral artery and vein. Actually, the upper or the proximal part of femoral artery and vein, so we can say the proximal 3 to 4 centimeters or the proximal part of femoral vessels is covered by modification of deep fascia which is called as femoral sheath. Now, here in this diagram you can clearly appreciate that femoral nerve is lying outside the sheath. Femoral nerve is lying outside the femoral sheath. So, femoral sheath. So, now I just want you to show this schematic diagram which is very easy for you to understand. The femoral sheath is covering the upper 3-4 centimeters of or the proximal part of femoral vessels. The femoral nerve is lying outside the sheath and this is merging with the adventitia layer of the femoral vessels. It is divided into 3 compartments. The lateral compartment of femoral sheath contains femoral artery along with the femoral branch of genitofemoral nerve. The intermediate compartment contains femoral vein, and the medialmost compartment, which is also called as femoral canal, contains deep inguinal lymph node. So, what is femoral sheath? Femoral sheath is modification of deep fascia covering proximal, which is covering the proximal 3 to 4 centimeters of femoral vessels. Femoral sheath is divided into 3 compartments. The lateral compartment, the intermediate compartment, and the medial compartment. The medial compartment is called as femoral canal. The lateral compartment contains femoral artery and femoral branch of genitofemoral nerve. In short, I have written. The intermediate compartment contains femoral vein and the medial compartment contains deep inguinal lymph node. Deep inguinal lymph node, which is also called as lymph node of Cloquet or Rosenmuller. So, here you can see the medialmost part of femoral sheath is shown as a femoral canal, and we can see the femoral sheath covering the femoral vessels. Femoral nerve is lying outside the femoral sheath. Femoral canal upper, if I talk about femoral canal upper margin, or you can say upper base, you can upper margin, that is base, this is termed as femoral ring, and it is also important to know the boundaries of femoral ring. One more thing I want everybody to please note down, that femoral sheath, if I want to, it's very important that you should also understand this femoral sheath is formed from. So, anterior wall of femoral sheath is formed from fascia transversalis and the posterior wall of femoral sheath is formed from fascia iliaca. So, please note down, anterior wall of femoral sheath. Anterior wall of femoral sheath is formed by fascia transversalis and posterior wall of femoral sheath is formed by fascia iliaca. Now, Femoral ring, which is the upper border, femoral ring, which is the upper border of the or the base of femoral canal, and we have to know the boundaries of femoral ring, which is very important. So let's see the boundaries of femoral ring. The boundaries of femoral ring are following. Anteriorly, it is formed by inguinal ligament. Posteriorly, the femoral ring is formed by pectineus muscle fascia. Medially, the femoral ring is formed by lacunar ligament. What is lacunar ligament? Actually, this lacunar ligament is an extension, medial extension of inguinal ligament. And laterally, if you will see, it is separated from a femoral septum with femoral vein. So, laterally, there is a septum which separated from femoral vein. Now, femoral hernia. Now, what is the importance of this femoral canal? Because actually this femoral canal is an area of weakness, and it is seen in cases of females that femoral hernia is more common. The reason is that the females is having an wider pelvis, and the caliber of the vessels are less in comparison, and there is a chance that herniation can occur through this space. So here, if I talk about femoral hernia, at times what happens, the hernia is strangulated and immediate operation has to be done, and laparoscopic treatment of this herniation has to be done. So the surgeon should keep in mind that the most important is that the incision, if you want to enlarge the opening of femoral canal, you can either go for medial incision or you can go for extension along lateral aspect. So just showing you this image, can you see here? So if you will see this femoral canal, if the incision has to given laterally, which structure is injured? That is femoral vein. So it is not given laterally, it is given medially, and we know that medially femoral ring is having which structure? Lacunar ligament. Just see here. So medially there is lacunar ligament. But at times what happens, abnormal obturator artery is residing there, and there can be a cutting of abnormal obturator artery, and it can lead to enormous bleeding. Normally, obturator artery is a branch of anterior division of internal iliac artery, but sometimes there can be a presence of abnormal obturator artery, which is located on the medial aspect or medial boundary of femoral ring, and it can be accidentally cut, and it can lead to enormous bleeding. So, abnormal protrusion. So, this femoral hernia is more common in females. And the reason I have told you, wider pelvis and the lower caliber of the femoral vessels. So this is the case of herniation. You can see the herniation is occurring below inguinal ligament and lateral to pubic tubercle. Now, here you can see the femoral sheath anterior wall is formed by fascia transversalis, and the posterior wall of the sheath is formed by fascia iliaca. Now, as I told you, now for example, you can see this is the hernial sac, and you can see it is protruding from the femoral canal, and in this case we want to do the treatment as quickly as possible because it's an strangulated one, so it's an emergency situation. So for enlarging it, we can't cut. So here please note down. Okay, so here I just please write down. So this is femoral vein and this is femoral artery. So if you go laterally incising, you can cut the femoral vessels. Okay. So only surgeons prefer, and it has been preferable side that we can enlarge that opening by going to cut the lacunar ligament which is residing medially. But the problem is that in few of the individual, there is the abnormal obturator artery, which is a branch of inferior epigastric artery, which can be accidentally ligated and cutted in this situation, and this can lead to enormous bleeding. So please note down abnormal obturator artery. Abnormal obturator artery is branch of inferior epigastric artery. And normal obturator artery will be a branch of anterior division of the internal iliac artery. So done with this, now it's important to solve few MCQs related to this. Psoas abscess. Actually, we know the psoas muscle, psoas major iliacus muscle. These are the muscles which is coming from the lumbar region and then inserting onto the lesser trochanter of femur. That means infection of the lumbar vertebrae or tuberculosis involving this can ultimately lead to the infection traversing via psoas muscle into the lower limb. So this leads to the formation of psoas abscess. Now let's talk about the MCQs. Lateral dislocation of patella is prevented by which of the following structure? Rectus femoris, vastus intermedius, vastus lateralis, vastus medialis. Lateral dislocation of patella is prevented by which of the following structure? My dear aspirants, the attachment of vastus medialis is more area on the patella. So, if I talk about vastus medialis, it's a very important muscle inserting onto the base of patella and the medial aspect or border of the patella bone. The extent of vastus medialis muscle is more extending onto the medial border and the medial aspect of the patella. So, lateral dislocation of patella is prevented by which muscle? The answer is vastus medialis. Strongest flexure of hip joint. This is very important. Actually, we know that the muscles which I am talking about is sartorius is also causing flexion, and the other muscles which is located in the anterior aspect of the thigh is causing the flexion of the hip joint. But if I am talking about the strongest flexure of hip joint, the answer is iliacus and psoas major muscle. So, the strongest flexure is iliacus and psoas major muscle. Rectus femoris is the part of quadriceps femoris. One of the important muscle which is residing in the anterior compartment of thigh is quadriceps femoris muscle. Quadriceps femoris muscle is having four components. Why it is called as quadriceps femoris? Because it is four-headed. Its components are, it contains vastus medialis, it contains vastus lateralis, vastus intermedius and rectus femoris. Now, being rectus femoris being a part of muscles of anterior compartment of thigh, quadriceps femoris, and we know the action of quadriceps femoris is knee extension and hip flexion. So, the answer will be hip flexion and knee extension. Actually, all the quadriceps femoris muscle, all the group of quadriceps femoris muscle, that is vastus medialis, vastus lateralis, vastus intermedius and rectus femoris are all having the action common, that is hip flexion and knee extension. Now, talk about the fourth question. Action of sartorius muscle includes all except. So, sartorius muscle is a very important muscle which is also called as Taylor's muscle, and it is involved in, you must be knowing the Palthi position in yoga, and also some of you must be in old times they just sat on the floor in Palthi position and then they eat the food. So, the action of sartorius muscle is similar to the Palthi position or similar to that position which the Taylor adopted in the older times. So, action of sartorius muscle is all except. Sartorius muscle, if I talk about the action of sartorius muscle, it is causing flexion, abduction and lateral rotation of hip and also the flexion of the knee. So, here the odd man out is extension of leg, which is not the correct answer. Extension of leg is not a function of sartorius muscle. All of you please note down the function or action of sartorius muscle. Sartorius muscle action. The action of sartorius muscle is, it causes flexion, abduction and lateral rotation of hip. Along with it, it also causes flexion of knee. Which is the medial most component in the femoral triangles? Just now we have talked in detail about the femoral triangle and we have to know which is the medial most component of femoral triangle. The answer is, the medial most component is lymphatics. We know that deep inguinal lymph node, navel, and here L stands for lymphatic. So, medial most component is deep inguinal lymph node. All are the content of femoral triangle except. So, we have got following options. We have got femoral artery, femoral vein, nerve to pectineus, superficial inguinal. Please don't get confused with nerve to pectineus. Actually, nerve to pectineus is a branch of femoral nerve which is also given in femoral triangle. So, nerve to pectineus is branch of femoral nerve which is given from the trunk part of femoral nerve, and it is also the content of femoral triangle. But we know that superficial inguinal lymph node is the content of roof of femoral triangle. So, the odd man out or the correct answer here will be C. Superficial inguinal lymph node is not the content residing inside femoral triangle. It is the deep inguinal lymph node which is lying inside. Superficial inguinal lymph node is located in the roof of femoral triangle. Now, all are the content of femoral sheath except femoral artery, femoral nerve, femoral vein, genitofemoral nerve. We know that femoral artery and genitofemoral nerve are the content of lateral compartment of femoral sheath. Femoral vein is the content of intermediate compartment and femoral nerve is lying outside the femoral sheath. Let's talk about adductor canal. So, adductor canal is the adductor, if you will see the femoral triangle, you can just enlarge this image. So, here you can see this triangular structure is femoral triangle. After that, the femoral vessels traverses through the opening of adductor magnus muscle and ultimately will reach and pass through adductor hiatus, that is opening in adductor magnus muscle, and will reach the adductor canal. So, this you can say adductor canal is a passage which is allowing the femoral vessel to pass in the adductor canal hiatus and ultimately reach the popliteal region. So, the other name of adductor canal is, it is also called as Hunter's canal, or it is also called as subsartorial canal. So, why it is called as, it is important for us to know why it is called as Hunter's canal and why it is called as subsartorial canal. So, actually John Hunter was a great surgeon and a great anatomist of his time. So, in regard to John Hunter, it was named as Hunter's canal because he was the first to start a operation for the treatment of popliteal aneurysm, in which he was ligating, he started the procedure of ligating the healthy part of the femoral vessels in the adductor region for the treatment of popliteal aneurysm. Subsartorial canal, why it is called as subsartorial canal? We know that sartorius muscle is forming the roof or the medial wall of adductor canal, and beneath it we have got nerve plexus. 3 nerves are residing there. Together they are forming subsartorial nerve plexus. So, it is also called as subsartorial canal. I will give you the details of the 3 nerves which is together forming the subsartorial nerve plexus. Now, let's see the boundaries of adductor canal. So, there is an anterior view and there is also a transverse section which will help you to understand the boundaries of adductor canal. So, if I talk about its boundary, medially it is bounded by sartorius muscle, posteriorly by adductor longus and adductor magnus. Let me just enlarge this. Posteriorly by adductor longus and adductor magnus, anterolaterally by vastus medialis. So, and we have got a list of many structures residing in the adductor canal. Few of the structures has been shown: nerve to vastus medialis, femoral artery, vein and saphenous nerve. Other than that, we also have got the anterior and posterior division of obturator nerve residing and also the femoral artery branch, that is descending genicular artery. Also, you can see this is sartorius, and can you see the black dots which is shown here is actually the nerve plexus, that is subsartorial nerve plexus. So, please note down the boundaries and the content of adductor canal. Adductor canal. Adductor canal roof or medial wall is formed by sartorius muscle. Anterolaterally it is bounded by vastus medialis muscle. And medially it is posteriorly it is bounded by adductor longus muscle along with adductor magnus muscle. Now, so done with this. The next important point is to know the content of adductor canal, and then I would like to tell you about the subsartorial nerve plexus. So, please firstly note down subsartorial nerve plexus. As I told you, beneath the sartorius muscle, we have got nerve plexus, and 3 nerves are contributing in the formation of subsartorial nerve plexus. These nerves are medial cutaneous nerve of thigh, saphenous nerve, the anterior division of obturator nerve. So, please note down the 3 nerves are medial cutaneous nerve of thigh, saphenous nerve, and that of anterior division of obturator nerve. It supplies the overlying facial artery and the skin. Now, talking about the contents of adductor canal. So, please write down the heading. content of adductor canal. Content of adductor canal are the content of adductor canal is following. It contains femoral artery and its branches, the descending genicular artery, and descending genicular artery also gives a saphenous branch in this area of adductor canal. The other content is femoral vein, the saphenous nerve to vastus medialis, and anterior and posterior division of obturator nerve. Anterior and posterior division of obturator nerve. Anterior and posterior division of obturator. These are all the contents of adductor canal. Now, so we have done with this. Now I would like to show you this cadaveric image and we can solve few MCQs. So here in this diagram, you can clearly see the sartorius muscle. And as I told you, this sartorius muscle is forming the roof of adductor canal, and inside we can see the contents residing inside. So inside we can appreciate the contents, and the contents which is residing inside are femoral artery, which is shown here. Also we can see the saphenous nerve. And we can see the vastus medialis muscle, forming anterolateral wall. It is forming the anterolateral wall for the adductor region. Now let's solve few MCQs related to the this topic. All of the following pairs regarding the adductor canal is correct except roof. Roof is formed by sartorius muscle, content is femoral nerve, okay, floor by adductor longus and magnus, anterolateral by vastus medialis. So all of this match the following is correct because floor is also called as the posterior wall. So yes, it is formed by adductor longus and adductor magnus. So we definitely know that femoral nerve is not a content of adductor region or adductor canal. So definitely the right answer will be the content which is written here is femoral vein is absolutely wrong. So femoral nerve is absolutely wrong. Femoral nerve is not the content of adductor canal. Let's read the next MCQ. Which of the following structures passes through adductor magnus muscle or adductor hiatus? The adductor magnus. The right answer is femoral vessels, femoral nerve, femoral sheath, saphenous nerve or tibial nerve. The right answer here is femoral vessels. Femoral vessel traverses through the opening of adductor magnus muscle. Coming to the third MCQ, what is true about the adductors of thigh? Which of the following statement is true about the adductors of the thigh? Okay, the options are: ischial head of adductor magnus is an adductor part. Profunda femoris is the main blood supply. Ischial head of adductor magnus originate from adductor tubercle. Adductor magnus is the largest muscle. So my dear, when I am talking about adductors of thigh, I mean to tell that adductor compartment of the thigh. That means I am talking about adductor compartment of the thigh, and in the adductor compartment of the thigh, the largest muscle is the adductor magnus. So this is definitely the most correct answer. So here, profunda femoris is the blood supply is also partially correct, but profunda femoris artery also give blood supply to the adjoining area, not only to the medial compartment. Ischial head of adductor magnus is not adductor part, but it is the hamstring part of adductor magnus muscle. Ischial head of adductor magnus originate from ischial tuberosity and not from the adductor tubercle. So the best correct answer is adductor magnus is the largest muscle of adductor region. Let's talk about back of thigh. Now, hamstring muscle is the together muscle. So actually back of thigh is together is called as hamstring muscle, which is mainly made of semimembranosus, semitendinosus, long head of biceps femoris, and adductor magnus ischial part which is comprising the hamstring part. So, these 4 muscles are forming the hamstring group of muscle. Now, there is common features of hamstring muscle. If I talk about hamstring muscle, they are all having similar origin, they are all having similar nerve supply and action. So, if I talk about hamstring muscle, it is just the antagonist of the anterior muscle like quadriceps femoris muscle. So, hamstring muscle is contracting and working as an agonist. So, if I talk about the action of hamstring muscle, it is flexing the knee and extending the hip. The antagonist action will be done by quadriceps femoris. It will extend the knee and flex the hip. Now, characteristic feature of hamstring muscles are, so the common features of hamstring muscle is following. It arises from ischial tuberosity. It inserts on one of the bone of the lower leg, so either tibia or fibula it is inserting. All are supplied by having a common nerve supply, that is tibial part of sciatic nerve. All are the flexors of the knee and extensor of the hip. All the muscles are together called the flexors of the knee and extensors of the hip. Now, so I would also like to elaborate that if I talk about the hamstring muscle, there is an important point which has to be noted. Adductor magnus is the muscle which is not following the rule of insertion of one of the bone of the leg, that is tibia or fibula. Actually, it ends at the level of adductor tubercle, and we know that adductor tubercle is the part of femur bone. Actually, lower to it, it forms a ligament. The name of that ligament is tibial collateral ligament. So, tibial collateral ligament, it is also called as medial collateral ligament, and this is the degenerated tendon of the adductor magnus muscle. Which part? Hamstring part, which is on the medial side of the tibia. So, definitely this is also going towards the leg bone, and it is also according to the rule. But if you will see directly, you know that adductor magnus muscle inserting into adductor tubercle, that is present in the femur. Okay, now I told you all the muscles of hamstring group is originating from ischial tuberosity. Now, in this diagram, you can appreciate that this has been divided by a transverse ridge into upper and the lower part. Again, the lower part is divided by an longitudinal ridge into lateral and medial, and the upper part is divided by an oblique ridge into supralateral and supromedial part. If I talk about the supralateral part, the muscle originating is semimembranosus, supralateral. If I talk about the supromedial part, 2 muscles are originating from this, semitendinosus and long head of bicep. If I talk about the lateral most part of ischial tuberosity, lower part, adductor magnus is originating, and the medial most part lower down of this ischial tuberosity is having no muscle attachment. Now, let's talk about the nerve supply. Among these muscles, if I talk about semimembranosus, semitendinosus and long head of biceps, all is getting innervation from tibial component of sciatic nerve. The odd man out is short head of the biceps femoris, which is getting innervation from common peroneal part of the sciatic nerve. Adductor magnus, the hamstring part, is tibial component of sciatic nerve, but its adductor part is getting innervation from the obturator nerve. These all we have done in general anatomy also. So, if I talk about the action of all these muscles together, all these muscles are the flexors of the knee and extensors of the hip. Now, sciatic nerve, as I told you, short head of biceps is getting innervation from common peroneal component. All other muscles are getting innervation from tibial component of the sciatic nerve. So, here if I talk about sciatic nerve, it is giving no branches in the pelvic region. In the gluteal region, it gives this is showing you the branches of which nerve? Sciatic nerve. Sciatic nerve is the thickest nerve of our body, and it gives no branches in the pelvic region. In the gluteal region, it gives articular branch to hip. In the back of the thigh, it gives muscular branches, and we know that from its tibial component, it gives innervation to semitendinosus, semimembranosus and the hamstring part of adductor magnus. And from common peroneal component, it gives innervation to short head of biceps. Here also the long head of biceps are also getting innervation from tibial component. Let's talk about few MCQs. All are branches of lumbar plexus except All of the following are branches of lumbar plexus except iliohypogastric, ilioinguinal, obturator and subcostal. So the odd man out, subcostal is having the root value T12 and the odd man out is the subcostal nerve. So subcostal is not directly a branch from lumbar plexus. What is the root value of sciatic nerve? As I told you, sciatic nerve is the thickest nerve of our body and it is formed by ventral rami of or anterior rami of L4, L5, S1, S2 and S3. So the right answer is root value L4, L5, S1, S2 and S3. Gluteus maximus muscle inserts on. I told you in iliotibial tract, two muscles are inserting. One is gluteus maximus muscle and other is tensor fascia lata. True statement regarding origin and insertion of piriformis muscle. When I talk about a piriformis muscle, it is originating from the iliacus part of the hip bone, also take origin from the sacrum adjoining area and insert into greater tubercle. So the right answer will be piriformis muscle originating from the sacrum ilium and inserting into GT, that means greater trochanter of femur. Now, muscle attached to the lateral aspect of greater trochanter. Actually, too many muscles attaches on greater trochanter. I will give you the list of the muscle being attached into the greater trochanter. So, which is attached onto the lateral aspect of greater trochanter? The correct answer is gluteus medius. So, all of you, please write down this. Muscle attached onto the greater trochanter. So, please note down some important muscles. Gluteus medius muscle is attached onto the lateral aspect of greater trochanter of femur. Gluteus minimus muscle attached onto the anterior border of greater trochanter of femur. Piriformis muscle is attaching onto the apex of greater trochanter of femur, just proximal to the or prior to the attachment of obturator internus, gemellus superior and gemellus inferior. Now, gemellus superior, obturator internus and gemellus inferior. This three muscle together inserts onto the medial aspect of greater trochanter. Now, onto the medial aspect of greater trochanter of femur. Other than that, there is one more muscle that is called as obturator externus. Actually, obturator externus is inserting into trochanteric fossa of femur, and actually this trochanteric fossa of the femur is also onto the medial side of the greater trochanter. So these are few muscle which is having close insertion close to the greater trochanter of the femur. So please note down that. Now, gluteus medius is supplied by which of the following nerve? Gluteus medius. So it's also important for you to note down the nerve supply of gluteus medius and gluteus maximus. Gluteus medius and minimus both are supplied by superior gluteal nerve. So please note down gluteus medius and also gluteus minimus. Both of these are supplied by superior gluteal nerve. If I talk about gluteus maximus muscle, this is supplied by inferior gluteal nerve. Now, positive Trendelenburg sign is associated with. Actually, this is a very important clinical aspect which everybody should know. If I am talking about this Trendelenburg sign, it is seen in case of injury of superior gluteal nerve. We know that superior gluteal nerve is giving innervation to gluteus medius and minimus, and the action of gluteus medius and minimus is abduction of the thigh. And positive Trendelenburg sign is seen in paralysis of gluteus medius and minimus. So the correct answer will be abductors of thigh, because the action of both gluteus medius and that of gluteus minimus muscle is, prime action is, they are abductors of hip joint. They are abductors of hip joint, and they are also involved in supporting when a person is standing on one leg. So see this diagram. In normal condition, when you stand one leg footed on the ground, the other side of the hip is slightly raised up and supported by the contralateral side, gluteus medius and minimus. If gluteus medius and minimus is injured due to injury to superior gluteal nerve, in cases of injury to superior gluteal nerve, there is paralysis of gluteus medius and that of minimus. So both are paralyzed. So the other side or the contralateral side of the hip is sagging down as shown in the diagram, and they are unsupported, and this is called as Trendelenburg sign. And we know that the contralateral side action, that is abduction of the thigh, is helpful for supporting the unsupported hip when you are standing on one leg. So this is called as Trendelenburg sign positive, which is seen in condition of superior gluteal nerve injury. So yes, done with this. Now I would like to talk about a few more important topics of lower limb part 2. So let's start with the lower limb part 2. So for the lower limb part 2, you have to know the retinaculums, you have to know the flexor retinaculum, you have to know the extensor and peroneal retinaculum, and what are the structures traversing below it. So here in this diagram, you can see the flexor retinaculum. Very nicely you can appreciate its flexor retinaculum. The flexor retinaculum, if you will see the attachment of the flexor retinaculum, so let me just show you. It attached from medial malleolus to that of medial tubercle of the calcaneum bone. So this is the attachment. And flexor retinaculum is modification of deep fascia, and many structures are traversing below it. It is important for us to know the structures traversing below. There is a very important mnemonic. I will write it and tell you. The structures traversing below or beneath flexor retinaculum from medial to lateral are tibialis posterior, flexor digitorum longus, posterior tibial artery nerve, and then we have got flexor hallucis longus. The mnemonic is Tom, Dick, Bloody, Nervous, Harry. So please write down about flexor retinaculum of foot. Flexor retinaculum of foot. Flexor retinaculum of foot is modification of deep fascia. It's a modification of deep fascia extending from medial malleolus to medial tubercle of calcaneum. To medial tubercle of calcaneum bone. Now, what is important for us to know? The structures traversing beneath flexor retinaculum of the foot. So, please, I would like to give you a mnemonic for this. So, please note down. So, all of you please write down. Structure passing beneath flexor retinaculum of foot. Structure passing beneath flexor retinaculum of the foot. The mnemonic is Tom, Dick, Bloody, Nervous, Harry. So these are the structures traversing from medial to lateral. These are the structures traversing from medial to lateral. So here T stands for tibialis posterior, D stands for flexor digitorum longus, B for the blood vessels, that is posterior tibial artery, N for the nerve, that is tibial nerve. and here H stands for flexor hallucis longus tendon. So, please remember this mnemonic. Tom, Dick, Bloody, Nervous, Harry is the mnemonic for structures traversing below flexor retinaculum of the foot. Now, let's talk about, let's see few images. So, let's see few images for it. So, the same thing has been shown here, in which you can clearly see the flexor retinaculum and you can appreciate. So, the same thing has been shown here. If you will see, I have just highlighted that. So, you can clearly see Tom for tibialis posterior, Dick for flexor digitorum longus, Bloody for the posterior tibial artery, Nervous for tibial nerve, and Harry for flexor hallucis longus. Now, let's talk about extensor retinaculum. Before that, few other images I want to show. Here, this is an image showing partial dissections, and you can see the tibialis posterior tendon, flexor digitorum longus tendon close to it. So, you can see these two tendons are here. This is the tendon of tibialis posterior. Close to it is the tendon of tibialis, close to it is the flexor digitorum longus, and then you can see the vessels and nerve. So, there is posterior tibial artery and that of the tibial nerve. Now, here you can see the dissection has been done, and very nicely they have appreciated the two tendons here. One is tibialis posterior and the other is flexor digitorum longus tendon, and the most laterally is the flexor hallucis longus tendon. Now extensor retinaculum. If I talk about extensor retinaculum, you can just see this image. Extensor retinaculum, I just want to highlight this extensor retina. So, we have got two extensor retinaculum. One is superior extensor retinaculum, and the Y-shaped which you are seeing is the inferior extensor retinaculum. So, this is superior extensor retinaculum. This Y-shaped structure which you are seeing is the inferior extensor retinaculum. This is superior extensor retinaculum and this is inferior extensor retinaculum. This is superior extensor retinaculum and this is inferior extensor retinaculum. The attachment of superior extensor retinaculum is on the anterior lower aspect of tibia fibula. It's on the anterior surface of fibula to that of anterior border of tibia. If I talk about inferior extensor retinaculum, it extends from the calcaneus bone and get attached to the medial malleolus, and that too it merges with the sole of foot, deep fascia of the sole of foot. So, that is about. Now, here also you can see here. So, firstly let me write it and then I will show you the structures and I will give you a mnemonic for remembering the structures traversing beneath the extensor retinaculum. So, write down. Again, we are knowing that extensor retinaculum is modification of deep fascia. Extensor retinaculum is of two types. One is superior. So, one is superior extensor retinaculum. When I am talking about superior extensor retinaculum attachments, it attaches to the anterior surface of the fibula. It attaches on the anterior surface of the fibula to anterior border of tibia, to anterior border of tibia. If I talk about inferior extensor retinaculum, attachments, it is attaching. So, it is attached to the calcaneum bone. It is extending from the calcaneum bone to medial malleolus. Actually, we know that inferior extensor retinaculum is Y-shaped. So, this will be the superior slip, and the inferior slip if I talk about, which is extending from calcaneum, it will merge with the and fuses with the deep fascia of sole. Deep fascia of sole. It will merge with the deep fascia of sole. So, done. So, this is about the attachment of extensor retinaculum. Now, I would like to give you a mnemonic for structures traversing deep to the extensor retinaculum of the foot. Okay, I think this will be easy for you to understand. So, see this image. So, yes. So, let's talk about from medial to lateral. If I talk, this is medial side and this is the lateral side. The structures traversing is tibialis anterior, extensor hallucis longus, anterior tibial artery and deep peroneal nerve, extensor digitorum longus and peroneus tertius. These are the structures traversing beneath extensor retinaculum. So, and same thing has been shown here. So, but I want everybody to note down a mnemonic for remembering this. So, write down the heading: structures passing beneath extensor retinaculum. Beneath extensor retinaculum. Structures passing beneath extensor retinaculum. So, we can have a mnemonic for this. Write down: tall husbands are never dear person. So, the mnemonic is, please mark these words: tall husbands are never dear persons. So, here T stands for tibialis anterior muscle, H for extensor hallucis longus muscle tendon, A for artery anterior tibial artery, N for deep peroneal nerve, D for extensor digitorum longus, and P for peroneus tertius muscle, PT, peroneus tertius muscle. Peroneus tertius muscle. Okay, same way which if in the starting point I have told you about the flexor retinaculum, here I am telling you about the extensor retinaculum. So, very nicely you can appreciate that, and these are the structures traversing from medial to lateral beneath the extensor retinaculum. Tall husbands are never dear person. Tibialis anterior, extensor hallucis longus, anterior tibial artery, deep peroneal nerve, the extensor digitorum longus and peroneus tertius. These are the tendons traversing beneath the extensor retinaculum of the foot. So, done with this now. So, here I can show you a cadaveric image where you can see the extensor retinaculum has been removed, and you can see the tendons of tibialis. You can see the tendons of tibialis anterior, extensor digitorum longus, which is traversing beneath it. There is a peroneal retinaculum in the lateral aspect, and two structures are traversing below peroneal retinaculum. One is peroneus longus, another is peroneus brevis. Two tendons are traversing below peroneal retinaculum. And the two tendons which is passing below peroneal retinaculum is the tendon of peroneus longus and peroneus brevis muscle tendon. Now, let's talk about the joint. When I am talking about, so in lower limb, I want also to cover up the joints. So, I also want to cover up the whole joints and the nerves. So, it's very important because, so briefly we will discuss about all the joints and the nerves of lower limb. So, one of the joint which I am showing you is the knee joint, which is the most complex joint in our body, and it's the most complex and the compound joint. So, why I am telling compound? So, I will clear the concept of complex and compound. Compound because generally the joint is formed by articulation of two bones, but here the articulation is via three bones. So, it is formed by lower end of femur articulating, upper end of the tibia, femoral condyle and the tibial condyle along with the patella contribution. So, how many bones are articulating? Three bones. So, it is compound. Complex, if you will see the joint cavity of knee joint, what you can see, there is meniscus lying inside. Actually, meniscus are also called as semilunar cartilages. Okay, so there are two menisci. One is medial meniscus and the other is lateral meniscus. These are termed as semilunar cartilage, which is dividing the joint cavity into upper segment and the lower segment. So, the upper compartment is called as meniscofemoral compartment and the lower compartment is called as meniscotibial compartment. Now, when in the upper compartment, flexion extension of the knee is going on, conjunctly medial and lateral rotation is going on in the lower compartment, that is meniscotibial compartment. So, this makes the knee joint the most complex joint in our body. So, have you got the have this point clear why knee joint is the most compound and complex joint in our body? Now, other than that, I also want everybody to note down all the ligamentous support of the knee joint. So many important ligaments are there which is giving support to the knee joint. So, I want first everybody to note down the ligament and then I will show you the attachment of these ligaments. So, please write down the list of ligaments of the knee joint. Ligaments of knee joint. The ligaments of knee joints are following. Fibrous capsule is there. Fibrous capsule is there. We have got collateral ligaments. We have got medial and lateral collateral ligaments. So when I am using the word medial and lateral collateral, and the other term is medial for tibial and lateral for fibular collateral ligament. We have got two cruciate ligament, that is anterior and posterior cruciate ligament. We have got two meniscus, medial meniscus, we have got lateral and we have got medial meniscus, which is called semilunar cartilage. Other than that, we have got ligamentum patellae. Other than that, we have got oblique popliteal ligament. We have got arcuate ligament. We have got coronary ligaments. So my dear aspirants, if I talk about the ligaments, the primary support is given by fibrous capsule, medial lateral collateral, cruciate ligament, meniscus, ligamentum patella. So these are the primary ligaments of the knee joint. Accessory ligaments are, which is giving secondary support. These are accessory ligaments, which are oblique popliteal ligament, arcuate ligament and coronary ligament. Now, the fibrous capsule, if you are seeing the capsular attachment in the knee joint, it is on the joint, it is onto the articular surfaces of the joint, and it is onto the margins of the joint, and it is also actually what happens, fibrous capsule is having some of gaps. It is having a gap for the tendon of popliteus muscle. Anteriorly, there is a gap for the suprapatellar bursa ligamentum patellae, and it's very important for the joint support. Interior of the fibrous capsule, which is onto the attachment of the articular margins of the knee joint with certain gaps, which I have told you, is having synovial membrane, which secretes synovial fluid for the smooth lubrication of the knee joint. Now, ligamentum patella is actually formed from the tendon of which muscle? So ligamentum patella is formed from the tendon of quadriceps femoris muscle. So actually quadriceps femoris muscle, which is together inserting into the patella, will lead to the form ligamentum patellae. Here you can see this is the ligamentum patellae, which is formed by the tendon of quadriceps femoris muscle. So this is quadriceps femoris muscle and this is ligamentum patellae. Now, collateral ligament, as I told you, there are two collateral ligaments. One is medial and another is lateral. So, medial collateral ligament, if you will see, is having two parts. So, let me just explain this. So, what you can see, this is a medial collateral ligament, which is having a deep part which is merging with medial meniscus and superficial part which is going on to the proximal aspect of the tibia. When I am talking about lateral collateral ligament, it is having an attachment from the lateral epicondyle to the fibula, head of the fibula. So, what you can say, laterally the knee joint is supported by fibular or lateral collateral ligament, which is having just one part, but the medial collateral ligament is having two parts, the deep and the superficial part. The common origin is from medial epicondyle of the femur, as same as lateral collateral ligament is having origin from the lateral epicondyle of the femur. The medial collateral ligament merges with the medial meniscus, but you can note down that lateral collateral ligament is separated from the lateral meniscus. It is not joining the lateral meniscus, it is separated, and so it means that medial collateral ligament and medial meniscus will be conjointly injured. Now, one more thing I want you to tell here for your MCQs, the medial collateral ligament is the degenerated tendon of ischial part of adductor magnus muscle, and lateral collateral ligament is degenerated tendon of peroneus longus muscle. So, please write down this. Medial collateral ligament is degenerated tendon of ischial part of adductor magnus muscle Lateral collateral ligament is degenerated tendon of peroneus longus muscle. Peroneus longus muscle. Now, cruciate ligament. When I am talking about cruciate ligament, how many cruciate ligaments are there? There are two cruciate ligaments. One is the anterior and another is the posterior cruciate ligament. These cruciate ligaments are important for antero-posterior stability of the knee joint. Now, here you can see this is the anterior cruciate ligament and this is the posterior cruciate ligament. Both are crisscrossing each other. So, these two cruciate ligaments, as you see here, they are crisscrossing to each other, so they are called as cruciate. Anterior and posterior cruciate ligaments are important for antero-posterior stability of the knee joint. Now, again, other than that, I want you to show this image where you can appreciate semilunar cartilages. Now, we have got two semilunar cartilages. The medial and lateral meniscus are called as semilunar cartilage, dividing the joint cavity into two compartments. Other than that, one more thing I want you to tell, which all structures in the knee joints are intracapsular? The answer is the cruciate ligaments and that of the meniscus and also that of the popliteus tendon. So, these are important things which you should know. Other than that, in this you can say there are actually semilunar cartilage. We have got two, medial meniscus and lateral meniscus. If you remember, I told you medial meniscus was, this is lateral meniscus and this is the medial meniscus. So almost rounded shape is of lateral meniscus, but semilunar shape is of medial meniscus. Actually, meniscus are made of fibrocartilages. They are example of fibrocartilages. They are important for dividing the joint cavities into the two compartments, and they are intracapsular structures. Other than that, what is important is medial meniscus is adherent to tibial collateral ligament, so the chance of more injury is on the medial meniscus. Lateral meniscus is not adherent to lateral collateral ligament and to the fiber. They have got an attachment to popliteus tendon. So, please note down, semilunar cartilages are made of fibrocartilage. Medial meniscus is more prone to injury than lateral meniscus. And we know that if medial meniscus is more prone to injury, and we know that medial meniscus is adherent to which structure? It is adherent to medial collateral ligament. So, medial collateral ligament will also injured along with the medial meniscus. Now, here I want you, so these were the primary support, and other than that we have got secondary supports in the knee joint. Oblique popliteal ligament. So, what you can see in the case of oblique popliteal ligament, so actually it is arising from the expansion of the tendon of semimembranosus muscle. This is oblique popliteal ligament and it is having certain gaps. So, oblique popliteal ligament is formed from the expansion of the tendon of semimembranosus muscle, giving support to the posterior aspect of the knee joint. It is pierced by the middle genicular nerves and vessel and by the posterior division of obturator nerve. So, please write down oblique popliteal ligament is formed from the expansion of, semimembranosus muscle. It is pierced by oblique popliteal ligament. It is pierced by posterior division of obturator nerve and middle genicular nerves and vessel. Middle genicular nerves and vessels. Now, Bursas around the knee joints are suprapatellar bursa, prepatellar bursa, infrapatellar bursa, and pec anserine bursa. Pec anserine bursa is on the medial proximal part of tibia. Prepatellar bursa and infrapatellar bursa are more anteriorly. Superiorly, we have got suprapatellar bursas. Now, there are certain clinical points about these bursas. When these bursas are inflamed, the condition is called bursitis. I will tell you about that. Before that, I want everybody to note down the important action of the muscle. So, I want everybody to note down the muscles involved in the different actions of the knee joint. So, one of the important action is locking and unlocking of knee joint. When I am talking about locking and unlocking, you have to understand. In case of locking of knee joint, all the ligaments are taut, and locking occurs as a result of medial rotation of femur during the terminal stage of extension. When I am talking about unlocking, unlocking occurs by lateral rotation of femur during the initial stage of flexion. Unlocking is done by popliteus muscle and locking is done by quadriceps femoris muscle. To be more precise, which component of quadriceps femoris, the answer is vastus medialis. So please write down about locking and unlocking of knee joint. Locking of knee joint is result of medial rotation of femur during terminal phase of extension of knee. Unlocking of knee is result of lateral rotation of femur during initial phase of flexion of knee. Now unlocking is done by popliteus muscle. Locking is done by quadriceps femoris muscle, which is having 4 component. And if you want to know the most important component which is involved in locking of knee joint, the answer is vastus medialis muscle. Now, so before proceeding to the applied anatomy, I would like everybody to note down the muscles performing this actions. The muscle performing this action. So please note down actions of knee joint. Action of knee joint. Now, extension of the knee is done by following muscle. Extension of knee is done by quadriceps femoris muscle. And we know that quadriceps femoris muscle is made of 4. Quadriceps femoris is made of 4 components. What are they? They are vastus medialis, vastus lateralis, vastus intermedius, and rectus femoris. Flexion of knee is done by posterior back muscle of the thigh. Flexion of knee is done by biceps femoris, more by the long head, semitendinosus, semimembranosus. The medial rotation of the knee is done by popliteus muscle along with semimembranosus, semitendinosus, and lateral rotation of knee is done by biceps femoris muscle. Now, coming to applied anatomy. If I talk about applied anatomy, terrible triad of knee joint. Actually, when it is called as terrible triad of knee joint, I will tell. When there is an injury of 3 important ligaments, it's called as terrible triad. The 3 important ligaments being injured are, what are the 3 important ligaments being injured? There is tearing of anterior cruciate ligament along with medial meniscus and medial collateral ligament. It is seen in rugby football player when there is a direct hit on the knee joint, and it is terrible. Why? Because the full integrity of these ligament is not gained after the surgery also. So this is called as terrible or the unhappy or the O'Donoghue triad of knee joint. So 3 ligaments injured here. Unhappy triad of knee joint. Please note down the 3 ligaments injured in unhappy triad of knee joint. In unhappy triad of knee joint, the 3 ligaments being injured are anterior cruciate ligament, medial meniscus, and we know that medial meniscus is attached to medial collateral ligament. So, these together is forming the terrible triad. Now let's talk about housemaid knee. In case of housemaid knee, when we are using the word housemaid knee, there is involvement of inflammation of one of the bursa of the knee joint, and the name of that bursa is prepatellar, subcutaneous prepatellar bursa. So, other term for housemaid knee will be subcutaneous prepatellar bursitis. And this is commonly seen in housemaids when they have got a work of rubbing the floor. Constant pressure is on the prepatellar bursa subcutaneous. Clergyman knee, this is seen in priest who has the who always do prayers in the kneel down position, and ultimately there can be involvement of inflammation of the subcutaneous infrapatellar bursa. So, clergyman knee is due to inflammation of subcutaneous infrapatellar bursa. So, it is also called as subcutaneous infrapatellar bursitis. Pec anserine bursa, and we know that 3 muscle tendons. So, there is 3 muscle tendons. Sartorius is there, semitendinosus is there, and gracilis is there. These 3 muscle, if I talk about sartorius, it is the muscle of anterior compartment of the thigh. If I talk about semitendinosus, it is the muscle of posterior compartment of the thigh. If I talk about gracilis, this is the muscle of medial or adductor compartment of the thigh. That means sartorius muscle is originating from anterior superior iliac spine, semitendinosus from ischial tuberosity, and gracilis from the adjoining area of the ischium and the pubis. 3 muscles having 3 origin from the different area of the hip bone, but they have got a common insertion, and the common insertion is on the proximal medial part of tibia, and this common insertion is called as pec anserine, because 3 muscle being originating from 3 different area have a common insertion. So, only they are called as guy rope muscle, and there is a bursa related to these 3 muscle, and if there is inflammation of these bursa, it is called as pec anserine bursitis. Now, let's talk about the next joint. Okay, knee joint and hip joint. One important point is that you should know knee joint is a type of which joint. It's a modified hinge joint. So, one of the common thing which I didn't tell you, because I thought everybody is knowing that. If I talk about knee joint, it is modified hinge joint, hinge synovial joint. Actually, the articulation between femoral and tibial condyle becomes an example of condylar joint. The articulation between the articulation which is taking place between the femur and patella is an example of saddle type of articulation. Hip joint, if I talk about hip joint, it is an example of ball and socket type of synovial joint. Ligaments. So, firstly, I want to write the important ligaments, name of important ligaments of the hip joint. So, the important ligaments are fibrous capsule, the important ligaments are fibrous capsule, iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament, acetabular labrum, transverse acetabular ligament, and that of round ligament of hip joint. Now, my dear aspirants, the primary ligamentous support is given by fibrous capsule, iliofemoral, pubofemoral, and that of ischiofemoral along with acetabular labrum. So, these are primary support for the hip joint. Accessory support is given by Accessory support is given by transverse acetabular ligament and round ligament of hip joint. Now, we know that hip joint is an example of ball and socket. So, I just want you to show this images where you can see the attachment of fibrous capsule is on the acetabular margin and the trochanteric line anteriorly. So, both images has been shown. This is the, here both images has been shown, and this is the image which is shown anteriorly. So, this is the anterior view of the attachment of fibrous capsule. This is the posterior view of attachment of fibrous capsule, where you can see the posterior view, the inferior margin, if you will see, the inferior margin of attachment of fibrous capsule is 1 centimeter above the intertrochanteric crest. Now, the 3 ligaments has been shown. Iliofemoral ligament, it's one of the strongest ligament of the body, which is preventing the body from downward falling back because of the support of iliofemoral ligament when the person is standing erect. Pubofemoral ligament is controlling excessive abduction of the hip, and ischiofemoral ligament is controlling excessive internal rotation of the hip. Ischiofemoral ligament gives posterior support to the hip joint. Pubofemoral ligament, iliofemoral ligament, as we can see, this iliofemoral ligament is Y-shaped, attached to the anterior inferior iliac spine, merges with intertrochanteric line, and pubofemoral ligament merges with the anterior aspect of iliofemoral ligament, very important for the anterior support of the hip joint. So, please write down. Pubofemoral ligament limits excessive abduction of hip joint. Iliofemoral ligament limits excessive limits backward fall when a person is standing erect. So, you can say excessive hyperextension of the hip. Ischiofemoral ligament is limits excessive internal rotation of hip, Now, accessory ligaments I want to show you. Here you can see again the acetabular labrum has been shown. Acetabular labrum is on the margin. In the interior you can see the round ligament of head of femur, and you can, so I also want to tell that if I talk about head of the ligament, if I talk about this round ligament of femur, it is not giving any support. But the blood supply to the hip joint is traversing through it. Here I just want you to show this diagram. Here you can see this is the round ligament of head of femur. Here you can see which is cut here, and here you can see the margin is having the margin will have the articular cartilages, and also this will have the labrum, which is deepening the joint cavity and giving more support to the hip joint. Also, what you can appreciate here, the round ligament of head of femur, if you will see, you can clearly see there is acetabular notch, and this acetabular notch is bridged by the transverse acetabular ligament. So, round ligament of head of femur is merging with its base is merging with the transverse acetabular ligament. So, they are giving secondary support to the hip joint. Now, movements of the hip joint is very important. Movements of the hip joint, we have to know all the muscles performing the movements of the hip joint. So, flexion of hip joint is primarily done by psoas major and iliacus muscle. Other flexors are pectineus muscle, rectus femoris muscle, and sartorius muscle. Extension movement, if I talk about extension movement, the extension. So, actually it's very important to know all this. This diagram is showing the movements of the hip joint, you can appreciate it. So, as it is a ball and socket type of joint, so the movement occurs in 3 degrees of freedom, 3 planes. And flexion, extension, abduction, adduction, medial and lateral rotation, all is possible on this multi-axial hip joint. So let's talk about, we have already talked about flexion. Let's talk about the extension of the hip joint muscle. Extensors of the hip joint are following. It is done by gluteus maximus muscle and the hamstring group of muscle. And I know that hamstring group of muscle is already known to you. We have got semitendinosus, semimembranosus, long head of biceps and ischial head of adductor magnus muscle. Now, further movements. So, let's talk about the adductors of the hip. The adductors of the hip are following muscle: adductor magnus muscle, the adductor brevis muscle, the adductor longus muscle, and that of gracilis and pectineus muscle. Gracilis and that of pectineus muscle. These are adductors of hip joint. Now coming to the abductors of the hip joint. If I am talking about abductors of the hip joint, the abductors of hip joint are following. The prime abductors of hip joint are gluteus, medius and minimus, along with tensor fascia lata. Now coming to the medial rotators and lateral rotators of the hip joint. Medial rotators and lateral rotators of the hip joint. M are for medial rotators. The medial rotators of hip joint are anterior fibers of gluteus medius and that of gluteus minimus. The lateral rotators are all the small muscle which is covered under gluteus maximus. And what are they? The lateral rotators are the obturator internus and obturator externus muscle, quadratus femoris, the superior and inferior gemelli, and also piriformis muscle. So done with this. Now next joint which I want everybody to understand is the ankle joint. Why I am stressing much on the joints? Because this is very important not only for your anatomy but also for your ortho questions. So ankle joint. If I talk about ankle joint, it is a hinge joint and it's a very strong joint. It is formed by the lower end of tibia and fibula articulating with the talus bone, articulating with the superior aspect of the talus bone. Ankle joint is hinge joint. Actually, it is also having fibrous capsule and two important ligaments, that is the medial ligament of ankle joint and lateral ligament of ankle joint. So, firstly, I want you to explain the medial ligament of ankle joint. So, the other name of medial ligament of ankle joint is, so just see this. If I talk about medial ligament of ankle joint, the medial ligament of ankle joint is also called as the deltoid ligament. Medial ankle ligament is also called as deltoid ligament and it is a very strong ligament. It's a very strong ligament. Why it is strong? Because it is having 4 parts. All the 4 parts has been shown in this image. So, for understanding that, I will show you the enlarged view. See here. So, its components are posterior tibiotalar. Its components are posterior tibiotalar, which is shown here. This is the posterior tibiotalar. Posterior tibiotalar. This is the posterior tibiotalar and this is the anterior tibiotalar. So actually, just remember the name. When I am using the word posterior tibiotalar, it is connecting the medial malleolus superiorly to the talus bone, medial tubercle of the talus bone posteriorly. Anterior tibiotalar is lying on the anterior aspect and from the lower aspect of medial malleolus, it is going towards the talus bone. So, these are the 2 components which I have written, first and second. The third component is the tibiocalcaneum. When I am using the word tibiocalcaneum, just see here the tibiocalcaneum. If I talk about tibiocalcaneum, see here. This is the tibiocalcaneal part of, or the third part of the deltoid ligament, which is merging with this sustentaculum tali of the calcaneum bone. So, this is the third component, sustentaculum tali. It is merging, this is the tibiocalcaneal part, which is called as the, which is attaching from the upper aspect medial malleolus lower to the calcaneum bone with the sustentaculum tali of the calcaneum bone. This is the third component. The fourth component is tibionavicular. The tibionavicular attached from the medial malleolus and goes forward towards the navicular bone, and it also merges here with, as you can see, it also merges with plantar calcaneo-navicular ligament. So, you can clearly see this is the fourth part, tibionavicular, which is also merging with plantar calcaneo-navicular and going towards the navicular bone from the medial malleolus superiorly. Plantar calcaneo-navicular ligament is also called as spring ligament. So, in other words, we can say the four parts of the deltoid ligament or medial ankle ligament is posterior tibiotalar, connecting the medial malleolus to the medial tubercle of the talus posteriorly, anterior tibiotalar connecting medial malleolus to the anterior aspect of the talus, tibionavicular, which is connecting the lower part of tibia, that is medial malleolus, to that of navicular tuberosity, tibiocalcaneal connecting from the medial malleolus of tibia to the sustentaculum tali of the calcaneum bone. The tibionavicular part also merges with spring ligament, which is called as plantar calcaneo-navicular ligament, Now, coming to the deltoid ligament. Now, coming to the lateral ankle ligament. So, deltoid ligament we have already done. Lateral ankle ligament is less strong than that of the deltoid ligament, but it is also giving support, and it is important for us to know the parts of the lateral ankle ligament. There are three components of lateral ankle ligament. So, upper attachment will be on the lateral malleolus. LM for lateral malleolus, that is lower end of fibula. Lateral ankle ligament is having three parts. Its first part is anterior talofibular. Anterior talofibular means connecting the lower end of fibula, lateral malleolus, to that of the talus bone. Posterior talofibular connecting the talus and the lower end of fibula, lateral malleolus, and calcaneofibular, which is connecting the lower end of fibula with that of calcaneum bone. So, three parts are there in the lateral ankle ligament: anterior talofibular, calcaneofibular, and posterior talofibular. In this case, I want you to tell that among this, the most common ligament involved in ankle sprain. So, the anterior talofibular ligament is, please note down, anterior talofibular ligament of ankle joint is most commonly injured or involved in cases of ankle sprain. Now, so done with this. Now, before proceeding to one more important aspect, I want you to tell about the movements of the ankle joint, and then I will talk about the Pott's fracture. So, please write down movements of ankle joint. Two important movements are taking place at the ankle joint. These movements are dorsiflexion and plantar flexion. Dorsiflexion and plantar flexion. The muscle causing dorsiflexions are the muscles of anterior aspect of the leg. Tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. The muscle causing plantar flexors are the muscles of posterior compartment of the leg. They are gastrocnemius muscle, soleus muscle, plantaris muscle, flexor hallucis longus muscle, flexor digitorum longus muscle, and tibialis posterior muscle. My dear aspirants, I also want everybody to please note down, we know that dorsiflexion and plantar flexion is the action which is taking place at ankle joint. Same way, there is another action which is called as eversion and inversion of foot, which is taking place at the subtalar joints. You have to know the muscle performing this action. So, please write down. Inversion and eversion of the foot. Inversion and eversion are taking place at which joint? Subtalar joint. Inversion at the subtalar joint. Inversion and eversion of the foot. So, this is subtalar joint. Subtalar joint. So, inversion of the foot is done by tibialis anterior and tibialis posterior muscle. Eversion is done by peroneus longus and peroneus brevis muscle. Now, coming to the applied anatomy, that is Pott's fracture. So, Pott's fracture is bimallular fracture. When I am talking about Pott's fracture, it is a bimallular fracture, but it can be trimallular. In the first, second stages, so you can just see here, in the first stage, there are 3 stages of Pott's fracture. In the first stage, there is an oblique fracture. There is an oblique fracture of the fibula lower end, that is lateral malleolus, and there is transverse fracture of medial malleolus, and this is the lateral malleolus. So, this is called as the bimallular Pott's fracture. The bimallular Pott's fracture. So, once more you can see in the lateral side there is oblique. So, you can just see here oblique fracture of lateral malleolus, transverse fracture of medial malleolus. This is medial malleolus, this is lateral malleolus, and there can be the third fracture, that is fracture of the posterior margin of the tibia, which is called as third malleolar fracture, and this becomes a trimallular fracture. So, please write down about Pott's fracture. So, Pott's fracture, that is also called fracture dislocation of ankle. In first stage, there is oblique fracture of lateral malleolus due to internal rotation of tibia, LM for lateral malleolus. In second stage, there is transverse fracture of medial malleolus due to pull of deltoid ligament of ankle. The third fracture is when it becomes trimallular, there is fracture of posterior margin in lower end of tibia, causing the fracture of third malleoli, and thus the bimallular Pott's fracture becomes trimallular fracture. Now, before that, I also want to briefly tell you other joints. So, there is also other joints here. So, if you will see this, yeah. So, please see this diagram where you can appreciate, in this diagram you can appreciate that there is talocalcaneonavicular joint. So, when I am talking about talocalcaneonavicular joint, this is an articulation which is taking place between navicular bone, talus bone, and that of part of calcaneum bone. So, talocalcaneonavicular joint is an example of ball and socket synovial joint. The subtalar joint, the other joint is subtalar. When I am talking about the subtalar joint is an example of plain type of synovial joint. It is an example of plain type of synovial joint. Now, also we have got calcaneocuboid joint, and calcaneocuboid joint is an example of saddle type of synovial joint. Now, the joints of the foot. So, in the foot we have got interphalangeal joint, which is hinge variety. Metatarsophalangeal joint is an example of ellipsoid, functionally ellipsoid variety of synovial joint. So, write down. Interphalangeal joints are that means in short I can write proximal interphalangeal joint, distal interphalangeal joint. These are example of hinge variety of synovial joint. Metatarsophalangeal joint. Metatarsophalangeal joint is an example of ellipsoid variety of synovial joint. Functionally. And the joint between the tarsus are plain synovial joints. Now, if I talk about articulation between tibia and fibula takes place at 3 levels. Proximal tibiofibular articulation is there, middle tibiofibular articulation is there, and distal tibiofibular articulation is there. So, if I talk about the proximal tibiofibular articulation, it's an example of plain type of synovial joint. The middle, which is joined by interosseous membrane, is an example of fibrous joint, and distal tibiofibular articulation is an example of syndesmosis. So please write down. Proximal will be an example of plain type of synovial joint. Middle tibiofibular joint is an example of fibrous joint, and distal tibiofibular joint is an example of syndesmosis. It's an example of syndesmosis. Now, a very important point which I want to explain is nerves of lower limb. So let's talk about nerves of lower limb. Important nerves. So already we have talked in brief femoral nerve. When I am talking about femoral nerve, it's the nerve of anterior compartment of the thigh. So in brief, just see this flow chart and you can understand. So the femoral nerve is originating from anterior rami of L2, L3 and L4. And it is having two division, anterior and posterior division. If I talk about its innervation, from the trunk, it is innervating iliacus and to the nerve to pectineus. From the anterior division, it is giving innervation to sartorius muscle and two cutaneous nerve, that is intermediate cutaneous nerve and medial cutaneous nerve of thigh. From posterior division, it is giving innervation to quadriceps femoris muscle and one cutaneous nerve which is called as saphenous nerve. It also give branches to the hip and knee joint. So if you can see this image where you can understand the cutaneous distribution of femoral nerve via its intermediate and the medial cutaneous nerve of thigh. So if I talk about saphenous nerve, what you can see, the saphenous nerve is going posteriorly. Actually, saphenous nerve is supplying the skin on the medial side of the leg and the foot till the level of great toe. So please write down, femoral nerve is formed by ventral rami of, femoral nerve is formed by ventral rami of L2, L3 and L4. So to be more specific, femoral nerve is formed by dorsal division of the ventral rami. Which division? Dorsal division of the ventral rami of L2, L3, L4. Femoral nerve anterior division supplies one muscle, that is sartorius muscle, and gives two cutaneous branches, that is medial cutaneous nerve of thigh and intermediate cutaneous nerve of thigh. The posterior division is giving innervation to quadriceps femoris muscle and saphenous nerve. From the trunk, the femoral nerve, if I talk about the trunk of femoral nerve is giving innervation to pectineus muscle and also innervation to iliacus muscle. So in short, what we have seen, we have written here. Now talking about obturator nerve. When I talk about obturator nerve, what you can appreciate, the obturator nerve is also formed by the anterior. So it is also formed by the anterior rami of L2, L3 and L4. So but the difference is that if I talk about femoral nerve, it is formed from, femoral nerve was formed from the dorsal division of the anterior rami of L2, L3, but obturator nerve is formed from anterior division of anterior rami of L2, L3 and L4. It is having two divisions, anterior and posterior. It is giving innervation to the muscles of medial compartment of the thigh. It is giving innervation to adductor longus, adductor brevis, pectineus, adductor magnus, obturator externus, and also gives innervation to hip joint and knee joint. And cutaneous distribution is on to the medial most part of the thigh. So see here, obturator nerve giving cutaneous distribution to medial most part of the thigh. Sciatic nerve, we have already told, formed by the ventral rami of L4, L5, S1, S2 and S3. The common peroneal component giving innervation to short head of biceps femoris. Tibial component is giving innervation to hamstring muscle. Now, I also want to tell that if I am talking about tibial nerve, this is the larger terminal branch of sciatic nerve giving innervation to the muscles of posterior compartment of the leg, and the common peroneal nerve, which is the smaller terminal branch. So, which is the smaller terminal branch of the sciatic nerve, and it is giving innervation to, it divides into two components, deep peroneal and superficial peroneal. So, just see here. So, you can see this is common peroneal dividing to deep and super. Deep is giving innervation to muscles of anterior compartment, superficial is giving innervation to muscle of lateral compartment of the leg. So, please write down this. Tibial nerve is larger terminal branch of sciatic nerve. It is the larger terminal branch of sciatic nerve. Root value is L4, L5, S1, S2 and S3. Innervates muscles of posterior compartment of leg. Actually, after motor branches, I will show you an image where you can see the cutaneous distribution of the nerve on the leg and the foot. The muscles innervated by tibial nerve are following: tibialis posterior, gastrocnemius muscle, both medial and lateral head, plantaris, popliteus muscle, flexor digitorum longus, flexor hallucis longus, soleus muscle. So, gastrocnemius, soleus, plantaris, popliteus, tibialis posterior, flexor digitorum longus and flexor hallucis longus. All gets innervated by the tibial nerve. Then the tibial nerve divides into medial and lateral plantar nerve, and that gives innervation to the sole muscles. Now talking about common peroneal nerve. When I talk about common peroneal nerve, the common peroneal nerve is smaller terminal branch of sciatic nerve formed by dorsal division of ventral rami of L4, L5, S1 and S2. L4, L5, S1 and S2 that we have already seen. See here, the common peroneal nerve is from L4, L5, S1 and S2. The tibial nerve is having all the component L4, L5, S1, S2 and S3. Tibial nerve is from anterior division, anterior rami of L4, L5, S1, S2, S3. Common peroneal is from dorsal division, ventral rami of L4, L5, S1 and S2. Now, the common peroneal nerve divides into two nerves. So, please write down common peroneal nerve. The common peroneal nerve, when winding around the neck of fibula, which is a common site of injury, and if it is injured, it can lead to foot drop. It divides into two branches. One is deep peroneal nerve and the other is superficial peroneal nerve. The superficial peroneal nerve is innervating the muscles of lateral compartment of the leg, peroneus longus and peroneus brevis. The deep peroneal nerve innervates the muscle of anterior compartment of the leg, that is tibialis anterior, extensor hallucis longus, extensor digitorum longus and peroneus tertius. Now, so you can see this is the common peroneal nerve and this is the superficial peroneal nerve. Distribution of cutaneous distribution you can see. Actually, if you will see so this is the superficial peroneal nerve which is giving distribution to more of the anterolateral part of the leg and the dorsum of the foot except the interdigital cleft. So, you can see the first web space interdigital cleft between the great toe and the adjacent toe, cutaneous distribution is by deep peroneal nerve. Now, same thing have been shown, common peroneal nerve area of distribution, cutaneous distribution, superficial peroneal nerve. Saphenous nerve will be on the medial side of the leg and will go towards the great toe. Deep peroneal nerve in the interdigital cleft. Sural nerve is going towards the lateral edge of the leg, lateral edge of the foot. Now, see here, I told you the tibial nerve divides into its terminal branch, that is the medial and lateral plantar nerves, and gives calcaneal branches which gives innervation to the sole structures. And also in this diagram you can see the cutaneous distribution of all the nerves here. MPN is the distribution of medial plantar nerve, LPN for lateral plantar nerve, calcaneal branches, SA for saphenous nerve, SU for sural nerve, SPN for superficial peroneal nerve and DPN for deep peroneal nerve. So, in mnemonic it is written and you can see the cutaneous distribution on the foot both on the dorsal aspect and the plantar aspect. Now, talking about the popliteal fossa. Popliteal fossa is a diamond-shaped depression which is lying on the back of the knee, and you can see this diamond shaped depression here, and the boundaries, you can appreciate the boundaries of the popliteal fossa. Semimembranosus is supromedial boundary, biceps femoris is supralateral boundary. So this is supromedial boundary. Biceps femoris is supralateral boundary. Gastrocnemius medial head is forming the infromedial boundary, and gastrocnemius lateral head is forming the infralateral boundary. Along with semimembranosus, we have also got the semitendinosus muscle tendon, which is forming the supromedial boundary. Now, the structures residing in the roof of popliteal fossa. The structures residing in the roof of popliteal fossa, the structures are following. It is consist of skin superficial fascia, which is having following structure. It contains sural communicating nerve, short saphenous vein, which drains into the popliteal vein, the posterior division of medial cutaneous nerve, and posterior cutaneous nerve terminal part. All these are the contents of the roof structure of the popliteal fossa, which is contained in the superficial fascia of the popliteal fossa. The contents which is residing inside, you can see here, the popliteal lymph node, the popliteal flat, the popliteal vein, the tibial nerve, and the common peroneal nerve. So, you can see the nerve. So, most important content of the popliteal fossa will be tibial nerve, popliteal vessels, the popliteal lymph node, and popliteal pad of fat. So, all this I have highlighted. Other than that, I want everybody to know that in the popliteal fossa, the popliteal artery gives its 5 genicular branches. It gives 5 genicular branches. So, you can see here the popliteal artery here is giving its 5 genicular branches. Middle genicular branch, the lateral inferior, lateral superior, middle superior, and inferior medial genicular branches. So, 5 genicular branches. So, you can write the contents of popliteal fossa. Contents of popliteal fossa are, the content of popliteal fossa are, please write down, popliteal artery and its 5 genicular branches, 5 genicular branches, popliteal vein, tibial nerve, common peroneal nerve, tibial nerve, common peroneal nerve, popliteal lymph node, and popliteal pad of fat. Now, so done. So, we have completed most important topics of the lower limb. Now, before summarizing this, I want a quick discussion of the MCQs related to the topic. So, inability to maintain the pelvis position while standing on one leg when the nerve is injured. So, if you remember, I have discussed this, and the inability to maintain the pelvis position when you stand on one leg is done by the injury of which of the following nerve? The answer is superior gluteal nerve. The answer is superior gluteal nerve, because superior gluteal nerve is giving, innervation to, it is giving innervation to the abductors of hip, that is gluteus medius and minimus. And when gluteus medius and minimus are paralyzed due to injury to superior gluteal nerve, Trendelenburg sign is positive. Now, deltoid ligament. If you remember, I told you deltoid ligament is medial ankle ligament of the ankle joint, and you have to tell what is not the attachment of deltoid ligament. The options are medial cuneiform, medial malleolus, sustentaculum tali, or spring ligament. So, medial malleolus, lower end of tibia, is definitely the superior attachment. It merges with the sustentaculum tali and the plantar calcaneonavicular ligament, which is also called as spring ligament. So, the odd man out and the correct answer will be, medial cuneiform. It is not attached to medial cuneiform. Same thing. Oblique popliteal ligament is expansion of which of the muscle tendon? This also I have explained. Oblique popliteal ligament is expansion of which muscle tendon? The answer is semimembranosus. Now, which 3 ligaments are injured in case of unhappy triad of knee joint? When I am talking about unhappy triad, which is also called as terrible triad of knee joint, 3 important ligaments are injured, and these 3 important ligaments are anterior cruciate ligament, medial meniscus, and tibial collateral ligament. So, the correct answer will be anterior cruciate ligament, tibial collateral, and medial meniscus. Which of the following condition is associated with lateral deviation of great toe? Lateral deviation of great toe is also called as hallux valgus deformity. Please note down, lateral deviation of great toe at metatarsophalangeal joint is called as hallux valgus deformity. All are branches of lumbar plexus except. So, mark the odd man out. We have already discussed it. It's the subcostal nerve because its root value is T12 and lumbar plexus is formed by L1, L2, L3 and L4 lumbar nerves. Abduction of thigh is limited by which ligament? The answer is abduction of thigh is limited by which ligament? We know the correct answer, that is the adductors, and the other ligament involved is pubofemoral. So, the correct answer is C. Tension of adductors and pubofemoral is the correct answer. When there is tension of adductors and pubofemoral ligament involved, it will limit the excessive abduction of thigh. Now, iliofemoral is not the correct answer. Why? Because it is limiting excessive backward movement of the hip, and also ischiofemoral is limiting excessive internal rotation of the hip. All of the following structures passes through lesser sciatic foramen except. The options are pudendal nerve, obturator internus muscle, internal pudendal vessel, nerve to obturator internus. All of the following structures passes through lesser sciatic foramen except. The structure is, and the right answer here will be obturator internus muscle. Obturator internus. Why? Because obturator internus muscle is not traversing through lesser sciatic foramen. It should be obturator internus muscle tendon. So, this is the right answer. Now, I have included this. Why? Because you can see the structures traversing through greater sciatic foramen, lesser sciatic foramen, and in exiting the greater sciatic and then entering the lesser sciatic foramen. So, you have to know the details of all this. So, please note down the structure. So, please note down the structures exiting from greater sciatic foramen are piriformis muscle, superior gluteal nerves and vessel, inferior gluteal nerves and vessel, nerve to quadratus femoris, sciatic and posterior femoral cutaneous nerve. So, this green box is telling you all the structures traversing through greater sciatic foramen. Now, the structure exiting only through lesser sciatic foramen will be the tendon of obturator internus muscle. In the option, it was not given the tendon, it was just mentioned obturator internus muscle. So, the correct option should be tendon of obturator internus muscle. When I am talking about the structures traversing from greater sciatic foramen and entering into lesser sciatic foramen, the structures are pin structures, pudendal nerve, internal pudendal vessel and nerve to obturator internus. Now, most anterior structure in the tibial plateau. Most anterior structures in the tibial plateau, which is the correct answer? Whether it is anterior horn of lateral meniscus, whether it is anterior horn of medial meniscus, whether it is anterior cruciate ligament of ligamentum patellar. The right answer is anterior horn of medial meniscus. It is the most anterior structure in the tibial plateau. For that, I would like to show you this diagram. So, see here. In this diagram, you can clearly see the tibia superior surface, and you can clearly see the most anterior structure here is the anterior end of medial meniscus. So, this is the anterior end of medial meniscus. This is the most anterior structure. The second structure which you are seeing here is the anterior cruciate ligament. Then we have got anterior end of lateral meniscus. So, this is anterior cruciate ligament and this is the anterior end of lateral meniscus. So, actually you can remember this three structure anteriorly by the Mnemonic Medical College, Lucknow. Then comes the posterior structure starting. So, that is posterior end of lateral meniscus, posterior end of medial meniscus, and the most posterior structure is the posterior cruciate ligament. So, thereafter we have got posterior end of lateral meniscus, then we have got posterior end of medial meniscus, and the most posterior most structure is the posterior cruciate ligament. Now, that means from anterior to posterior 6 structures are there. First, second, third, Medical College, Lucknow, Lucknow Medical College. The mnemonic to remember the structures residing the superior end of tibia from anterior to posterior is Medical College, Lucknow and Lucknow Medical College. So, this is the mnemonic. So, done with this. Now, let's move on to the next topic, head and neck. Now, Let's talk about head and neck. So in this topic, first thing which I want everybody to note down is the layers of the scalp. Okay, so you have to know the layers of scalp as starting from superior to interior. We have got following layers, and it is very easy to memorize the layer by the spelling of scalp, SCALP. So superficially skin, then is the connective tissue layer, then is the aponeurotic layer of the occipital and frontal bellies of the muscle, then we have got the loose areolar tissue, and then we have got the pericranium. So layers of the scalp you can remember by the spelling of scalp, that is skin, subcutaneous layer, that is connective tissue layer, the aponeurotic layer, then we have got the loose areolar tissue layer, loose connective tissue, areolar tissue, and the fifth is the perosteum. Now, here you have to note down the dangerous layer, which is the dangerous layer of the scalp. So, please note down. So, you have to just note down the dangerous layer of the scalp. So, please write down. Dangerous layer of scalp is fourth layer. What is that layer? That layer is loose connective tissue layer. That layer is loose connective tissue layer. This is the dangerous layer of the scalp. Now, why? The reason is it contains emissary vein. What is the reason? The reason is it contains emissary vein, and this emissary vein is forming communication between the veins of the scalp with that of dural venous sinuses. Now here in this diagram you can see the nerves of the scalp. So you can see the nerves of the scalp. We have got 8 sensory. We have got 8 sensory and we have got 2 motors. So all the 8 sensory, and we have got 2 motors nerves in the scalp. So 8 sensory are supratrochlear, supraorbital, zygomatico-temporal, auriculo-temporal. So if you will see here. Now see here. Here supratrochlear, supraorbital is the branch of ophthalmic division of trigeminal nerve. So here very nicely you can write how many sensory are there. So this images is showing. So just remove this. Yeah. So you can enlarge this. Yeah. I just want everybody to enlarge this image. So you just enlarge this image, and when you enlarges it, and then we can write the sensory branches. So sensory branches. So here supratrochlear and supraorbital are branches of ophthalmic, is the branches of ophthalmic division of trigeminal nerve. When I talk about zygomatico-temporal, it is the branch of maxillary division of trigeminal nerve. In short, fifth nerve I am writing. Auriculo-temporal is the branch of mandibular division of trigeminal nerve. Now, this is in front of the auricle, and behind the ear we have got other sensory nerves, great auricular nerve having the root valleys C2 and C3, lesser occipital, greater occipital, and third occipital. Now, other than that, I also want to tell about the arteries lying in the scalp region. That is, so if I talk about, so we have written the 8 sensory. What about? So this is showing the 8 sensory. What about the 2 motor which I didn't mention? Please write down. If I talk about the nerve supply of scalp, there is a total of 10 nerves in which 8 is sensory and 2 is motor. So please write down 2 motor nerves of scalp. So in that category we have got 2 motors. So we have got one temporal branch of facial nerve which gives innervation to frontal belly of occipitofrontalis muscle. If I talk about the posterior auricular branch, so the posterior auricular branch of facial nerve, it gives innervation to occipital belly of occipitofrontalis muscle. Done. Now, my dear aspirants, let's talk about the venous drainage of the scalp and the face. So, in this diagram, we can understand the venous drainage of scalp and face. So, I would like to explain it, which can be easily explained with the help of this image. So, actually, the most important vein or the largest vein of the face is facial vein. So, see here, I'm just enlarging it. So, if I'm enlarging it, Just concentrate on this diagram. What you can see, so you can just see the supratrochlear and the supraorbital vein, these two joints. Here you can see the supratrochlear and supraorbital, two joints here towards the medial side of the eye and medial, and ultimately leads to the formation of facial vein. So this is how the facial vein is formed, and facial vein is the largest vein. So you can just write down here, facial vein is the largest vein of the face. It's the largest vein of face. Now, it's the largest vein of the face. Now on just appreciate the formation of retromandibular vein. So now I want everybody to appreciate the formation of retromandibular vein. Yeah. So this is the retromandibular vein. And retromandibular vein is formed by joining. So if I talk about retromandibular vein, it is formed by joining two veins. It is formed by joining superficial temporal veins and the maxillary veins. So these two veins join together. These two veins, that is superficial temporal and maxillary vein, join together to form which vein? Retromandibular vein. So this leads to the formation of retromandibular vein. Now this retromandibular vein, after its formation, divides into two divisions. One is anterior division and the other is posterior division. The anterior division of retromandibular vein, the anterior division of the retromandibular vein joins with the facial vein to form common facial vein. So here you can appreciate the common facial vein is formed by joining facial vein and anterior division of retromandibular vein. It will ultimately drain into internal jugular vein. Now see here, let me use another color. So yes, now you can see the posterior division of retromandibular vein. The posterior division of retromandibular vein joins with the posterior auricular vein. So it is joining with the posterior auricular vein and leading to the formation of external jugular vein, and ultimately external jugular vein is draining into which vein? Subclavian vein. So this diagram is very easy for you to understand the scalp venous and the face venous drainage. Now, the next topic is triangle of neck. So I would like to tell you about the posterior triangle of the neck firstly, which is very important. The posterior triangle of the neck is located on the neck lateral side, and it is important to know the boundaries of posterior triangle of the neck. When I am talking of the boundaries of posterior triangle of the neck, let me just appreciate this image. So when I am enlarging it, if I enlarge this, you can appreciate the posterior triangle boundaries. So anteriorly, it is bounded by this muscle. So anteriorly, it is bounded by sternocleidomastoid muscle. This is sternocleidomastoid muscle, which is forming the anterior boundary. Posteriorly, it is bounded by trapezius muscle. See here. So this here, T stands for trapezius muscle and SCM stands for sternocleidomastoid muscle. Here, so I want black. So here, T stands for trapezius muscle and SCM stands for the sternocleidomastoid muscle, forming the boundaries. So here, anterior border of posterior triangle is formed by the posterior border of sternocleidomastoid, and posteriorly it is bounded by anterior margin of trapezius muscle, T for trapezius muscle. Also you can see this is omohyoid inferior belly. This is the muscle. So let me use another color. So yes. So this is the omohyoid inferior belly, which will divide the whole triangular space into upper triangular space, which is occipital triangle, and the lower triangular space as subclavian triangle. Apex is formed at the level of joining of the trapezius and that of sternocleidomastoid, which is taking place at the superior nuchal line, and the base is formed by the middle 1/3 part of the clavicle. So this is the base. So let me write the boundaries of posterior triangle. So all of you please write down the boundaries of posterior triangle. So please write down the heading. Boundaries of posterior triangle. The posterior triangle is formed by following structures. Anteriorly, it is bounded by posterior border of sternocleidomastoid muscle. Posteriorly, it is bounded by anterior border of trapezius muscle. Base is formed by middle 1/3 of clavicle. Apex is formed by at the level of superior nuchal line, where the sternocleidomastoid plus the trapezius muscle is joining. So, at that level, the apex is formed. Now, next is to know about the roof content and the floor content. Okay. So, yes, we have done with the nerves. I think in the scalp, I have forgotten about the arterial supply of the scalp. So, please note down the arterial supply of the scalp from before to backward. So, please write down this. I think we haven't finished that. So, write down arteries on scalp. There are 5 arterial supply on the scalp, and these 5 arteries are, please write down, from before to backward, before to back, anterior to posterior. So, from before to backward, these 5 arteries are supratrochlear, supraorbital artery, supratrochlear, supraorbital artery. Then we have got superficial temporal artery, and then we have got posterior auricular occipital artery, posterior auricular artery and the occipital artery. Now, my dear aspirants, here the supratrochlear, supraorbital and superficial temporal, they are lying anterior to the auricle, means anterior to auricle, and the last two are lying, that is the posterior auricular and occipital is lying posterior to the auricle ear. Here supratrochlear and supraorbital are the branches of internal carotid artery. Superficial temporal, posterior auricular and occipital arteries are the branches of external carotid artery. Now, so in the posterior triangle of the neck, we have talked about the boundaries, and I have already told you that the posterior triangle of the neck is divided into two triangular spaces. That division is done by omohyoid. Which belly of omohyoid? Inferior belly of omohyoid. The part of posterior triangle which is lying above the omohyoid, the belly, is called occipital triangle, and the part of posterior triangle which is lying below the omohyoid is the subclavian triangle. Now let's talk about the roof. The roof of posterior triangle is formed by investing layer of deep cervical fascia, and the roof is covered by superficial fascia and the skin. So, I also want everybody to note down the structures residing in the roof. So, in the roof, so see here, actually I just want you to show this cadaveric image. So, when you are seeing this cadaveric image, you can appreciate that the roof is containing external jugular vein. This is the roof content in the superficial fascia, and also it contains cutaneous nerve. It also contains cutaneous nerves. So, the cutaneous nerves are, so if you will see the cutaneous nerves are sprouting. So, you can see the cutaneous nerves are sprouting here, and there are 4 cutaneous nerves here. We have got the cutaneous nerves located. We have got the different lesser occipital nerve. We have got the greater auricular nerve. We have got transverse cervical, and those who are going down is the supraclavicular nerves. I will write it for you. So, these are important structures in the roof of posterior triangle. And the boundaries which is shown here, so you can clearly see the sternocleidomastoid muscle has been shown. This is the sternocleidomastoid muscle, the part of T for trapezius muscle, and the clavicle is shown lower down, and this is the apex part. So, this is the apex part. So, this part which you are seeing is the apex part. Now, please write down the roof structures. So, already I talked about roof of posterior triangle, and I have talked that it is formed by the investing layer of deep cervical fascia. And if I talk about superficial fascia, the superficial fascia of the roof of posterior triangle contains Platysma. What is platysma? It's an example of muscle in the superficial fascia. So, it's an example of panniculus carnosus muscle. It also contains external jugular vein. It also contains external jugular vein, and it contains 4 cutaneous nerve. It contains 4 cutaneous nerve. And what are they? 4 cutaneous nerves residing in the roof of posterior triangle. They are, please write down the name of 4 cutaneous nerve. They are lesser occipital nerve. They are lesser occipital nerve having the root value C2. They are greater auricular nerve having the root value C2, C3. They are transverse cervical nerve, transverse cervical nerve having the root value C2 and C3, and they are supraclavicular nerve having the root value C3 and C4. Now, let's talk about the floor of posterior triangle. When I am talking about the floor of posterior triangle, it is formed by prevertebral layer of deep cervical fascia. The floor muscles, so in the floor we will have the muscles of the posterior triangle, and the floor muscles are formed by semispinalis. As you go from top to bottom, it is semispinalis, splenius capitis, levator scapulae, scalenus medius muscle, and also sometimes there is first digitation of serratus anterior. All these muscles are plastered by prevertebral layer of deep cervical fascia, which is shown in this diagram also. So, please write down floor of posterior triangle. The floor of posterior triangle is covered by prevertebral layer of deep cervical fascia. The floor muscles are following. So, which are the floor muscles? The floor muscles are following from above to down. The floor muscles are following from above to down. They are semispinalis capitis, splenius capitis, levator scapulae, scalenus medius muscle, mainly this only, but at times can there be the first digitation of serratus anterior muscle. Now, so this is showing again the borders of the posterior triangle. As you can see, posterior border by trapezius, anterior by sternocleidomastoid, apex as superior nuchal line, middle 1/3 of clavicle is forming the base of posterior triangle. Now, the next important point, here also the muscles forming the posterior triangle, semispinalis, splenius capitis, levator scapulae and scalenus medius has been shown. The apex at the level of superior nuchal line, the base formed by the middle 1/3 of clavicle. Next important thing is to know the content of posterior triangle. As I told you, the posterior triangle is divided into, two triangular spaces, occipital triangle above and that of supraclavicular subclavian triangle below, and this division is done by inferior belly of omohyoid. So, I will like to tell you the contents individually. For that, I first want you to show this diagram. This is a schematic diagram helping you to understand the content of posterior triangle. So, with red color the structures residing in the occipital triangle. The occipital triangle is containing occipital lymph node, occipital artery, lesser occipital nerve, great auricular nerve, C3, C4 nerves, and also the 4 cutaneous nerve which I have mentioned: supraclavicular nerve, transverse cervical nerve, greater auricular and lesser occipital. 4 cutaneous nerves which is residing as a content in the roof of posterior triangle is actually sprouting from inside. So, that are important content of the occipital triangle. Other than that, one of the most important content of posterior triangle, which is sandwich between the roof and floor. If I am speaking the word sandwich between roof and floor, it means it is sandwiched between the investing layer of deep cervical fascia and prevertebral layer of deep cervical fascia, and the structure is spinal accessory nerve. Other than that, it contains occipital artery, dorsal scapular nerve. In the lower triangular space, that is subclavian triangle, in the lower triangular space, the subclavian triangles, if I talk about the lower triangular space, the subclavian triangle, it contains suprascapular nerve to subclavius, that is the branches from the trunk of brachial plexus upper, subclavian artery and subclavian vein and trunks of brachial plexus along with terminal part of external jugular vein. So, please write down. After that, next topic will be anterior triangle, but before that, all of you please write down the content of, all of you please write down the content of posterior triangle. So firstly, I would like to talk about the content of occipital triangle. The content of occipital triangle are, one of the most important content is spinal accessory nerve, sandwiched between the investing layer of deep cervical fascia and that of prevertebral layer of deep cervical fascia. Third and fourth cervical nerve directly. Then we have got dorsal scapular nerve, the four cutaneous nerves, which I have already told you, great auricular, transverse cervical, supraclavicular and the lesser occipital. Then superficial transverse cervical artery, and occipital artery and lymph nodes. Occipital, lymph nodes and occipital artery. Now next is to know the content of subclavian triangle. So please write down the content of subclavian triangle. The content of subclavian triangle. Write down the heading, the content of subclavian triangle. When I am talking about the content of subclavian triangle, it is also called as supraclavicular triangle, and the contents are third part of subclavian artery, actually subclavian vein. So you can write subclavian vessels, that is okay. Terminal part of external jugular vein, trunks of brachial plexus, also dorsal scapular artery is seen here, by suprascapular artery also sometimes, suprascapular artery, and also the associated lymph node, Okay. So done with this. So we have done with the important contents of subclavian artery also. Next is to start with the anterior triangle. So we have finished the scalp, we have seen the dangerous layer, we have seen the nerve supply of the scalp, we have seen the nerve supply, arterial supply and also the venous drainage of face and scalp, and we have seen the layers of the scalp, we have seen the details of the boundary of posterior triangle, content, subdivisions and the floor muscles. The next topic which I am going to start will be the anterior triangle. Okay, so let's have a break in between and then we can start again with the topic of anterior triangle, and we will discuss the content of individual 4 anterior triangles located in the entire anterior triangle, which is again divided into 4 sub-triangles. Like posterior triangle was divided into 2 sub-triangles, occipital and subclavian triangle. Okay,